Hi everyone, Dr. Macy here, and welcome back to another Virtual OSCE Prep video. Today, we're going to be talking about some basic orthodontic treatment options. There are lots of treatment options to go over, but once you know the indications for each one, you should be able to quickly select the correct answer choice or choices for each question. So let's go ahead and get started. Now, we said we would be talking about orthodontic treatment options, but I want to really clarify what these questions are after. The exam is not asking you to come up with an entire comprehensive treatment plan for a patient. They're just asking what the most appropriate initial management is. And what does that mean? This means that we may not be fully treating all of the patient's orthodontic needs with your answer choice, but you're choosing what would be the ideal place to start. You're basically going to be given clues or indicators with each patient that should point you to the best initial management option. The treatment options we'll go over today include the Lingual Arch, the Nance Appliance, the Transpalatal Arch, Cervical Headgear, Occipital Headgear, functional appliances, active removable appliances, anterior bite planes, posterior bite blocks, palatal expansion appliances, crossbite elastics, fixed appliances, clear aligners, extractions, orthognathic surgery, and habit-breaking appliances. So it's definitely quite the list, but once we start to break each one down, it becomes much more manageable. So let's go ahead and get started with our first option, the Lingual Arch. And here you can see an image of a lingual arch, also known as a lower lingual holding arch. And I really want you to look at the pictures for each of these treatment options so that their names make sense to you as you can functionally see what purpose they serve. Now, a lingual arch is a fixed mandibular space maintainer, and it's structured as a lingual wire attached to the molars. In an image, you can see that. It's bonded to the molars, and it runs along the lingual surfaces of the remaining teeth. So let's break down that description just a little bit. Fixed obviously means it's cemented or bonded in there, and the patient cannot remove it. Mandibular is also important. Notice how I called it a lower lingual holding arch. That is because these are only used really in the mandible. But why are they used? If we look back at that first point, this is a space maintainer. So if we remember when we talked about leeway space in previous lectures, we want to make sure that we maintain the additional space we gain from primary canine to primary second molar when transitioning to our adult dentition. We can lose the leeway space if the primary molars are lost early bilaterally and the permanent first molars mesially drift into that space. This causes an increase in crowding and can lead to much more difficult treatment later on. It is much easier to maintain space that is already present than to try and regain it. Now, an important piece of information is that this appliance will only be used if the permanent incisors are present. The wire lingual to the lower incisors is what is preventing the molars from drifting forward. Primary incisors are not stable enough to do this, and placing this appliance too early may interfere with the eruption of the permanent incisors. So, this appliance is a space maintainer, only used in the mandible, and it would be indicated in a patient who has bilaterally early loss of the primary molars, first or second, and for it to be the correct initial management treatment option, the patient also needs to have their permanent lower incisors present. On to the next. We have the Nance Appliance. This is also known as a Nance button, and as opposed to the lingual arch, this is a fixed maxillary palatal arch. It is comprised of bands on the molars extending to an acrylic anterior palatal button, which is why I said it's also called a Nance button. Now, it makes sense that this appliance would be in the maxilla only. There's no way you're putting this acrylic button in the mandibular arch. It has nowhere to go with the tongue, and there's no palate for it to rest against. Now, this appliance actually works similar, though, to the lingual arch we already discussed. It also serves to hold the molars back and prevents them from drifting forwards. It works because that acrylic button acts as anchorage. It's lightly pushing against the palate to hold those molars back. Now, although this can be used to prevent molars drifting for a few reasons, such as if a patient needed extractions and treatment, for the purpose of initial management on this exam, it's important to know that just like the lingual arch, it's also indicated when there is bilateral primary molar loss. If the maxillary primary molars are lost early, the permanent molars can drift forward, and we want to prevent that by maintaining the space. So for the sake of these questions, you can think of the lingual arch and the Nance as the same, with one for the mandible and one for the maxilla. The only difference is that because the Nance button is on the palate, you do not need all your maxillary permanent incisors to be present to use one. And next, we have the Transpalatal Arch, or the TPA. This is another fixed maxillary appliance that connects at the molars, but as you'll see, this one has no palatal acrylic button like we saw in the Nance. And that is because this is not serving just as strong or maximum anchorage like the Nance was, and therefore it has different indications. It's still used in the maxilla only. I would not want that wire with a loop resting underneath my tongue. And when only focusing on initial management, it can be used for unilateral primary molar loss. There's a lot that a TPA can do in orthodontics, but for this exam, I just want you to think about the fact that it doesn't have that acrylic button, so it's not as strong as the Nance. It cannot provide as much anchorage to hold back two primary molars, so it's used when there's only the loss of one. This appliance is helping prevent more mesial rotation of the molar than full mesial drift, and it's a space maintainer just like the first two appliances we went over. So if you see a patient who has only lost one primary maxillary molar, a TPA would be the best choice for initial management. And moving on from space maintainers to cervical headgear, which if you're not familiar, cervical refers to the neck. So as you can see from this image, the headgear strap is going around the patient's neck. And this is what we call an extraoral traction appliance. The patient will have these big tubes on the buccal surface of their upper molars, and this metal bow you see will slide into those tubes. The metal face bow then attaches to the strap, and the patient wears it as you see in this image. So the patient is putting this in themselves at home, and it is removable. Now there are different types of headgear, as you'll see soon, but this type specifically works in a cervical pull-down force direction. So if you just think about how this would work, that strap is pulling the metal bow, which is pulling the maxillary molars in a posterior and cervical or downward direction. And the purpose is to restrict maxillary growth. You are actively pulling that maxilla backwards, so it makes sense that this is used in class 2 patients with maxillary prognathism, or in other words, their maxilla is too far forwards. This is also best used in a young child around their growth spurt. It can help with overjet and overbite corrections that are often issues in class 2 patients. Now, what is very important about this treatment option being cervical headgear versus the other type of headgear we'll go over soon is the vertical component. This strap is pulling back, but also down on those maxillary molars, meaning they will experience extrusion. This will open up the patient's bite and is therefore best for patients with a low facial height pattern. Someone with a low anterior facial height is often presenting with a deep bite, so it's beneficial for them to get some molar extrusion and posterior bite opening. You would not want to use cervical headgear if someone already had a long face or open bite, as that would just make things worse. So if you see a class 2 patient with maxillary prognathism who is young and has a low facial height pattern, this is a great initial management option, if they'll wear it. But now let's discuss the other type of headgear, occipital headgear. And as you can see, hopefully from this image, it's a very similar appliance, but the direction of the force from the strap is very different. It's still pulling the maxilla back like the cervical headgear, but this particular extraoral traction appliance has an upward and backward force vector pulling towards the upper portion of the back of the head instead of the neck. It attaches to headgear tubes on the molars the same way as the cervical headgear, and it's still functioning to restrict maxillary growth. This means it's also indicated for patients who have class 2 occlusion due to maxillary prognathism. But because this strap is pulling the maxillary molars up instead of down, the molars will experience intrusive forces instead of extrusive forces. And this means that this is designed to treat patients with an open bite tendency rather than a deep bite. This also means it's beneficial for patients with an increased lower facial height, as intruding the maxillary molars will deepen the bite and therefore decrease the lower face height. So to recap, headgear will always be used in class 2 patients with maxillary prognathism. Cervical headgear is pulling down and is used in deep bite patients with a low facial height, while occipital headgear we see here pulls up and is used in open bite patients with an increased lower facial height. It's really important for these initial management questions to remember that distinction. Now, let's go ahead and move on to a category of treatment options that are very focused around utilizing the pubertal growth spurt, and that is the functional appliances. These are called functional appliances because they aim to change the function of the jaw muscles to correct malocclusion. Basically, what they're doing is they posture the mandible differently to encourage the muscles and soft tissues to change the occlusal relationship. These appliances are mainly used to treat patients with a class 2 skeletal discrepancy, especially in those with a retrusive mandible. Examples would include the Frankel, like you see here, that's removable. Other removable appliances include the twin block, the bionator, but there are also fixed options like the Herbst or Forceps. They will force the patient to posture the mandible forward, altering the muscles and soft tissue relationships to encourage occlusal changes. And because we are hoping for the best skeletal response as well, this needs to be done during the pubertal growth phase. This is not a treatment option that we want to do too early because it will take more time and be less efficient, and it's something that cannot be done after the growth spurt because no growth is occurring. You can only hope to modify growth when growth is actually occurring. This is also typically done as initial management or first phase orthodontic treatment before the patient gets comprehensive care. So if you see a class 2 patient, typically with a retrusive mandible who is in their pubertal growth phase, this is the optimal initial management. Now on to another removable option, the active removable appliance. This is a pretty unique option and one that's not utilized a ton as the first treatment option, but these appliances use built-in springs and screws to apply force to change tooth position, and that's what's meant by active. It may look kind of like a retainer you might have had as a kid, but certain aspects like the springs or wire bends or screws are active and their goal is to actively move teeth. Now, unlike functional appliances, these encourage natural growth during puberty and are actually somewhat limited in their scope. They're typically only able to achieve minor tooth movements like tipping a tooth, the correction of a single tooth, or a minor amount of expansion. A very common example of these is when there's a young patient, they come in and they have a single tooth and anterior crossbite. If they wear this appliance, then an active finger spring can be used to push that tooth labially and into the correct occlusion. So this is typically done during the growth phase and is usually a treatment modality used before a patient undergoes comprehensive treatment. You also only want to use these in a cooperative pediatric patient because they are removable. For an appliance like this to work, it needs to be worn the majority of the day, and if they're not cooperative and compliant, it just won't work. So if a young, cooperative patient doesn't want a fixed appliance and only currently requires limited tooth movement, this would be a great initial treatment option. Now moving on to another removable option that you may also see outside the world of orthodontics, an anterior bite plane. This is an anterior acrylic disocclusion appliance, meaning that it is disoccluding or disarticulating the teeth, allowing them not to touch. Now, unlike the active removable appliance, this is not actively moving teeth, it's just allowing the occlusion to change. And as you can see in this image, the acrylic is only positioned anteriorly, it's an anterior bite plane, meaning this is a great appliance for patients with a deep bite. By wearing this appliance, the bite is held open automatically, and the disoccluded posterior teeth are allowed to erupt. This will also help if someone's bite is so deep that there is incisal trauma risk. Some people have such a deep bite that the lower incisors are actually biting into or traumatizing the palate. This can be utilized later in treatment as well if we need to prevent a deep bite patient from biting off their braces. So if you see a patient with a really deep bite, you should be thinking of an anterior bite plane. And if we need to have an anterior disoccluding appliance, we also have a posterior acrylic disocclusion appliance known as the posterior bite block. Now this appliance is practically the opposite of the anterior bite plane. If you place acrylic between the anterior teeth, the posterior teeth will passively erupt and a deep bite is corrected. If you place acrylic between the posterior teeth, the anterior teeth will passively erupt and an open bite is corrected. So this is indicated when there is an anterior open bite or if posterior eruption control is needed. This removable acrylic appliance limits posterior eruption and allows for anterior eruption. Another important purpose for this appliance is the fact that it unlocks the bite, meaning it removes occlusal interferences. This can be really useful in a patient who has a unilateral posterior crossbite leading to a functional shift. So disoccluding the teeth can allow for that mandible to shift back to its normal position and allow for other treatment options that we'll discuss soon, like expansion. You can't expand the upper arch if the maxillary teeth are locked behind the mandibular teeth. So this will disocclude and allow for things to be expanded or moved. So just remember this is used to disocclude the posterior teeth, which is helpful in treating anterior open bites and as an adjunct when treating unilateral posterior crossbites. So since we just touched on expansion a little bit, let's talk a little bit more about it in depth. Because we have palatal expansion appliances, and these are fixed transverse maxillary expanders. These come in a variety of shapes and formats and can be used to fix different teeth. They can be attached to different teeth. You could be expanding in the front versus the back, but they're all serving to expand the maxillary arch. So obviously this would be indicated in patients with a narrow maxillary arch, which often leads to a posterior crossbite. By opening the mid-palatal suture, we can help get a patient out of that crossbite. This can also be used if there is a transverse skeletal discrepancy because you are actually widening the bone, the skeleton. Now, for most of these appliances, there is a screw in the middle, and the patient's parent will be instructed to turn that screw at home each day, with the number of prescribed turns being higher if they require more expansion. The type of expander used varies by the age of a patient. You can get more expansion before the pubertal growth spurt, meaning you can correct more severe cases before puberty with rapid palatal expansion, also known as an RPE. In older patients, you cannot achieve as much expansion because the mid-palatal suture becomes more interdigitated or like locked together, meaning you can only get mild or slow expansion in older patients. So if a patient has a transverse issue, like a narrow maxillary arch or a posterior crossbite, a palatal expansion appliance is certainly the initial treatment option to select. And remember, if they have a unilateral crossbite, you may also need some kind of posterior bite block to disocclude the teeth as well. Next, we have Crossbite Elastics. Now, I'm sure you're familiar with elastics or rubber bands that patients wear while in braces, but these crossbite elastics specifically are inter-arch elastic correction methods used for dental crossbite. So if one maxillary tooth is in crossbite, kind of like in this image, it's hard to tell, but looks like just about one, the patient will be instructed to attach an elastic from some attachment on the lingual surface of the maxillary molar down to the buccal surface of the mandibular molar. And the force from that elastic will help to correct the tooth in crossbite. Now, this does have a limited capability, so it's only used for minor transverse discrepancies. If a patient is in full crossbite, we would recommend a palatal expansion device instead, but with just one or maybe two teeth in crossbite, we should be able to get away with these crossbite elastics if the patient's compliant. So these are indicated for a patient with a minor transverse discrepancy, such as one tooth in posterior crossbite. And now we have the orthodontics classic, the fixed appliances, which is kind of just a fancy way of saying braces or a full arch bracket and wire system. Braces are the bread and butter of orthodontic treatment and are the comprehensive solution to fix many malocclusion and alignment issues. Unlike many of the previous treatment options we've gone over, they can be used to correct a variety of bite issues and are also often used after many of the early appliances are placed. So you might see this a little bit later in treatment, depending on the issues the patient has. These can be used in the mixed or permanent dentition, and depending on the treatment being done, patients typically have them on for a year, up to 4 or 5 years, depending on how severe they need treatment. Now, I won't go into in-depth about full fixed appliances because everyone should kind of be familiar with braces, but if you see a patient without a really specific issue who needs comprehensive alignment, then this is your best option. And another great option for similar issues is clear aligners. These are very popular nowadays and are a series of removable clear trays that are custom made to the patient. Each tray programs in a slight amount of tooth movement, and as the patient advances through their set of trays, the teeth will become aligned. Now, for the sake of the exam, you can say these are indicated for mild malocclusions, but aligner therapy is capable of a lot more than it used to be. You can use these to fix some pretty crazy things nowadays. But if a patient has a mild malocclusion and doesn't want to be put in full braces, these are a great and usually quick option. These are also typically the preference for aesthetically concerned patients because they're clear and less noticeable. So a lot of adults like this option as well. Compliance and wearing the trays is obviously the biggest concern, as it is with every removable appliance, but they can achieve really good results. So if you have an aesthetically concerned patient with a mild malocclusion and not a specific issue like crossbite or deep bite or any issue specific like that, then clear aligners should be considered. Now, moving back to a little bit more intensive of a treatment option, we have extractions, or the removal of selected teeth. Now, this is more common than people tend to think, and we're actually taught that about a fourth of orthodontic patients actually do require some extractions. Now, the indications for extractions should hopefully make some sense. All of the teeth are not going to fit in the mouth, or there are contraindications to keeping them, so we need to get rid of some. And this can present in a lot of ways, as severe crowding, as tooth size arch length discrepancy, to guide an eruption path, severe malocclusions, or just if a tooth is non-restorable. Now, let's go through these. If a patient has severe crowding, then some of the teeth may be blocked out of the arch or may not fit, so some teeth will need to be extracted. For patients with severe crowding, we usually take out 4 premolars, or if the crowding on the lower arch is not as bad, then we may take out just 1 mandibular incisor. A tooth size arch length discrepancy is kind of a fancy way of saying the teeth are too big for the jaws. And if the teeth are too big, they will not safely and comfortably fit, meaning some need to be extracted. For guiding eruption path, I want to stress that although orthodontic extractions is usually referring to the extractions of permanent teeth, primary teeth can be extracted as part of orthodontic treatment as well. For example, primary canines may be extracted earlier than they would actually exfoliate to guide the eruption path of the permanent canines if they look like they may be coming in at the wrong angle. Now, severe malocclusion can refer to a patient who is a whole cusp, class 2 or class 3, or perhaps a patient who has severe overjet. To correct that molar relationship, premolars may be extracted in both or just one arch, allowing the severe malocclusion to be corrected. And extracting also creates space for flared incisors to be retroclined back to a healthy position. And obviously, non-restorable teeth should not be maintained. You'll see that in all of dentistry. Now, we kind of have reached the most intensive or involved orthodontic treatment option, and that would be orthognathic surgery. And gnathic just means jaw, so this is the surgical correction of jaw discrepancies. Orthodontics can do a lot to correct teeth and occlusion, but there are times when there is a severe skeletal malocclusion that only surgery can fix. Sometimes the patient just has too far retrusive or protrusive of a jaw, or they are too skeletally open or narrow, and only orthognathic surgery will correct the issue. Obviously, this is not super common, but it should be a pretty clear treatment option to choose for a patient. A severe skeletal issue will be noted, and orthodontics alone would be insufficient to solve the patient's issues. And there are a lot of variations to what orthognathic surgery specifically is done for, but common examples include setting back or advancing the lower jaw, advancing the upper jaw, or even surgically expanding the upper jaw. This treatment can be used to treat anterior posterior, transverse, and vertical issues. It can also be a treatment option for patients with TMJ issues or obstructive sleep apnea. For TMJ, it really depends on what is causing the TMJ issues and what specific treatment they need, but sleep apnea can be seen if a person's mandible is too retrusive and is constricting their airway. So advancing their mandible through orthognathic surgery is certainly a helpful treatment option for that. But probably the most important thing to remember for this treatment option is that growth must be completed. You cannot do jaw surgery on a growing patient. If you surgically reposition the jaws to the perfect place, and then the patient keeps growing, they could grow right out of the corrected jaw positioning and require surgery again. It's very, very important that growth is monitored, such as with serial cephalometric x-rays, before a patient undergoes orthognathic surgery, as growth must be complete for this to be an option. So if you see a patient, likely an adult as they must be full grown, who has a severe skeletal malocclusion that orthodontics alone will just not fix, then orthognathic surgery is the best treatment option. And another common indicator for orthognathic surgery being needed is if a patient has obstructive sleep apnea, or maybe they just have really large concerns with their profile. Now, time to end with a pretty easy one after orthognathic surgery, and that would be a habit-breaking appliance. These are appliances that serve to interrupt oral habits, just as the name implies. And habits can include thumb sucking, tongue thrusting, or mouth breathing. And the major purpose of these appliances is to kind of remind the patient or prevent them from doing the habit. For example, the appliance that you're seeing here specifically is a type of thumb crib, which is a habit-breaking appliance used for patients who suck their thumb. Now, most of these patients almost do it subconsciously or when they go to sleep, so this crib is in place to contact their thumb and remind them not to suck it. I will emphasize that these will only work in patients that want to break the habit. This thumb crib is serving as a reminder to the patient, but if a patient really wants to suck their thumb, this crib is not going to stop them from doing that. They can physically get around it. But for the exam, this should hopefully be a pretty easy answer choice to know when to select. If the patient is presenting with a habit that needs to be controlled, then initial management should absolutely involve a habit-breaking appliance. All right, now that we've discussed all the initial management options, let's try a couple problems. If the patient is presenting with a habit that needs to be controlled, then initial management should absolutely involve a habit-breaking appliance. All right, now that we've discussed all the initial management options, let's try a couple problems. We have a 9-year-old male. His back teeth do not close the right way. He's had a unilateral crossbite for a 1.5 years, no previous treatment, asthma with an inhaler, narrow maxillary arch, and that unilateral posterior crossbite. We're being asked to select one or more answer choices for what is the most appropriate initial management. So, what indicators are we given in this question? The patient is young, he's only 9, and he has a unilateral posterior crossbite with a narrow maxillary arch. So one answer choice should automatically jump out to you for this patient, and that would be a palatal expansion appliance. His maxilla is narrow and certainly would benefit from expanding so we can get him out of that posterior crossbite. But I want you to think really carefully before solely selecting that as your answer. Remember how we discussed that it can be really hard to expand a unilateral crossbite because the teeth can be locked together? So in this case, we also would recommend some kind of posterior bite block to disocclude the teeth. Once the teeth are disoccluded, the maxillary teeth will be able to expand out of their crossbite. So the correct answer here would be J and K, posterior bite block and palatal expansion device. And here are the point values for this question. And you'll see that an active removable appliance, and Holly's just an example of that, is set at 0 points. Now, because this appliance can provide some minor expansion, and they can be built to include a bite block, it may work, but this is one of those questions where it's just not the best or the most appropriate option, so it was not the correct answer. And on to another one. We have a 10-year-old female, her front teeth stick out, she's had procline maxillary incisors since eruption, no previous treatment, class 2 molar relationship, and 7 millimeters of overjet, and we're given some Ceph values here. And we'll come back to all of these. Now we're being told to select one or more correct answers for what the most appropriate initial management is. So here we're looking to treat her class 2 occlusion, including both the molar relationship and that excessive overjet. And it's really important, like I said, to remember our normal Ceph values for questions like this, because this is how we will be given the clues and indicators for the specific treatment she needs. It'll tell us if it's a maxillary or mandibular class 2 problem, if she has an increased or decreased lower anterior face height, which hopefully be a little bit of a hint for you. So let's go through these. Normal SNA is 81, give or take 3, so hers is increased, meaning she has maxillary prognathism. Normal SNB is 79, so her mandible is normal, meaning we need something that will treat the maxilla, not the mandible. This means we can eliminate the functional appliance option, which is indicated for a retrusive mandible, and we're left with 2 headgear options for class 2 patients, cervical and occipital. But which one is indicated for our patient? Let's look at the rest of our Ceph values to determine that. Her selenasion to mandibular plane is 22, which is 10 degrees below the average, meaning she has a very flat mandibular plane angle. And alongside that, her Frankfurt horizontal to mandibular plane is 9 below average, meaning she also has a decreased lower anterior face height. So, since she has a low facial height pattern, we know that we want to open the bite by extruding the maxillary molars. This means that we need to pull down, and that is done with E, cervical headgear. And here are the point values for that question. Be sure to keep the indications for different types of headgear straight in our head. And another one. 9-year-old male, he has a gap when he bites in his front teeth, open bite increase since last visit, persistent thumb sucking habit, no previous treatment, 5 millimeters anterior open bite, procline maxillary incisors, and we've got a great picture to go along with it. And we gotta say, what is the most appropriate initial management? And hopefully, this is a pretty straightforward one for you to get some easy points on. The biggest indicator we are given is the fact that he has a persistent thumb sucking habit, meaning that we will not achieve any other orthodontic treatment goals until that habit is stopped. And because of that, the most appropriate initial management would be a habit-breaking appliance, making D the correct answer choice here. And here are the point values for that question as well. Pretty straightforward one here. Let's finish off with just one more. A 9-year-old female. We can barely see her bottom teeth when she bites, had this deep bite present for 3 years, regularly goes to the dentist, 6 millimeters of overbite, retrocline mandibular incisors, and procline maxillary incisors. What is going to be her most appropriate initial management? So in this patient, we're looking to treat her deep bite. She has the 6 millimeters of overbite, and her parents say they can barely see those bottom teeth when she talks. Now, a couple of these treatment options can help a deep bite, but only one is indicated when the deep bite is the only indicated problem. We're not told that she has class 2 or has any other big issues beyond this incisor proclination, so our initial management will just focus on the deep bite for now, especially because she's only 9. You could put braces on a patient and it'll fix a deep bite eventually, but she's only 9 and this deep bite is the core problem, so we want to consider initial management options. So the best option to treat that would be I, the anterior bite plane, Remember, this is that acrylic that is placed between the anterior teeth and allows for the posterior teeth to passively erupt, lessening a patient's deep bite. And here are the point values for that question as well. And that's everything for this lecture. I know it was a lot of treatment options to go over. Just try to keep the clear indications in your head so you can quickly select some and quickly eliminate others. Thanks so much for tuning in to learn about orthodontic treatment options. I'll see you in the next Virtual OSCE Orthodontics video.